Welcome to the Motivational Midwife. My name's Lynn Jones, and today we're going to be looking at postnatal care. So let's think about postnatal care then. So as always, what is the postnatal period? So it's generally defined as that first 6 weeks after birth. And during that time, it's when the woman's body returns to its as near pre-pregnant state as it can. From a uterine perspective, that's known as involution. And she'll establish feeding with her baby, be that breast or bottle. And interestingly, I always like to highlight this quote from the World Health Organization, which is actually, quite an old quote now, but it does say that this is the most vulnerable time for mothers and babies. And we can miss things if we're not really vigilant in this time. And as time's gone on, the postnatal period seems to be the period where we seem to really interact with women less and less and less as midwives. It really has become the Cinderella service of maternity at the minute. And that does concern me in that a lot of women are lucky if they're seeing a midwife maybe twice when they come home, unless there's something specific. And I do find that quite worrying, that we could be really supporting women in the postnatal period a lot better than we currently do. However, in our current environment, it is a challenge, definitely a challenge. Postnatal period although it does say it's up to 6 weeks, in most instances, most women will be discharged from our care around about day 10, and care will be handed over somewhere between day 10 and day 14 to the health visitor, who will take over as being the primary contact for her and her baby. So when we taking care in that postnatal period, where we've already covered in a different session the immediate post-birth postnatal care, but then there is the postnatal care we provide within the hospital environment, or if she's had a home birth, within the home environment post-birth as well. And then obviously when she does go home, there is our community midwives that are providing that postnatal care. And as I say, for most women, it will not go on for 6 weeks. But for some women, there may be contact that is kept between the midwife and the woman. I certainly know that in my own experience, many of the women that I actually maintained more contact with were actually women who had suffered some sort of fetal loss and just needed a bit more ongoing support. So generally things to consider. Obviously, you have to consider her physiological well-being as well as her psychological well-being. So, are things going back as you would expect them to be doing? Is her body doing what you are expecting it to be doing? There are pharmacological considerations to think about. So what type of delivery did she have? Does she need analgesia prescribing? Is the analgesia she got sufficient? Has she got venous thromboembolism risks? Does she need anticoagulants such as deltaparin or clexane? Documentation always is so important. And I would say even more so in the postnatal period when you are not seeing these women very often, because your documentation really gives a picture to the next healthcare professional that is taking over that care. So the more accurate and contemporaneous it is, the better it is for the next person coming in to see this family. Are there any safeguarding issues? And we're not talking just those high-profile involved children's social care safeguarding issues. You know, there's often much more lower level safeguarding issues, child in need safeguarding issues, where actually extra support is just required by the family, and you are in a very good position to start the ball rolling in that instance, to help that family get the extra support they need with this newborn baby. And it may be that it's the first time that any healthcare professional has actually been into the home environment of the family that you're caring for. So it may well be that that's the first time any concerns are raised. You need to think about infant feeding. How is she feeding? Does she need support with that feeding? If she's bottle feeding, has there been discussions around sterilisation and making up feeds? If she's breastfeeding, is she happy getting that baby on? Has those feeds been observed so that you know that she's fixing and attaching the baby correctly, so she doesn't get sore breasts? Does she know where she can access extra help? Think about your sphere of practice. We'll be working under our code of conduct, our NMC code of conduct, and the NMC proficiencies for registered midwives, as well as local and national guidelines. And within your sphere of practice, you do have a duty to refer when things fall outside of your sphere of practice. So that might be to the GP, that might be to children's social care, it might be to a physio. There's a whole ream of people that you might refer the family to, or the woman to. So there's when we looked at what happens antenatally, there are changes within all of these systems. Involution specifically is around the uterus and it returning to its pre-pregnant state. But there are hormonal changes, cardiovascular changes, respiratory, musculoskeletal, urinary and gastrointestinal changes. All the systems of the body are affected by pregnancy and birth. And postnatally, they will still continue to be affected, but those changes will start reversing. So thinking about the mother then, at postnatal visits, we should determine, is it appropriate to do a full set of observations on her? My personal practice when I was community midwife was the first day I would meet that mother, I would do a total postnatal examination. So I would do a full set of observations that would give me a baseline to work from, and determine her general well-being. You know, how is she feeling? What does she look like before you even speak to her? Look at her body language, how she's sitting, does she look pale? Does she look tired? Does she look like she's interacting with the baby? There's a lot you can pick up just by looking at someone before you've even started asking them how they are. So obviously it's not just the physical well-being we're thinking of, it's her emotional well-being as well. We're looking for signs of postnatal depression potentially, although very often that doesn't show itself until they have actually been discharged from our care as midwives. But it's important that they know about mental health and how they can access support for their mental health, and signs and symptoms that things may not be all well. So when you're doing a postnatal examination, be very systematic in your approach. So start at the top and work your way down. So we've already thought about, do we need to do observations? If she doesn't look very well, then I would say yes, do a set of observations. And as I say, my personal practice would be day one, and on discharge, I would do a full set just to make sure that I am discharging someone who is well. There's nothing that I'm missing. Moving down then, so the breasts. So antenatally, we know those breasts have enlarged. They've been producing potentially colostrum from about 16 weeks of pregnancy. Prolactin levels have been increasing, and now that baby is born, if she is breastfeeding, we're going to have oxytocin and prolactin levels also increasing. And we need to be, if she's breastfeeding, we need to be asking her how the breastfeeding, how she's finding the breastfeeding, you know, how her breasts are generally, has she got any pain when she's feeding. You know, it may be appropriate to watch her put the baby to the breast and see that it is actually latching well. Signpost her to any. There are some very good YouTube videos from UNICEF actually on fixing an attachment, which you can. I've certainly sent to a lot of parents because a lot of people like to actually see a visual resource. They find that easier. You know, are her nipples sore? What sort of advice are you going to give her if her nipples are sore? Most of the time, really around sore nipples, it is about making sure that the position and the attachment is correct. If she's not breastfeeding, if she is bottle feeding, you know, what information are you going to give her around natural suppression or, you know, of her milk supply? Because the body doesn't know she's chosen to breastfeed, so her milk will still come in whether she likes it or not. So you need to talk to her about not stimulating the breasts, about wearing a firm bra, analgesia if need be. And, you know, reassure her that if she's not stimulating her breast, that milk supply will generally just fade. Then looking at involution of the uterus. So really, involution happens. Remember, after the baby's been born, the placenta's delivered, you've got that contraction and retraction. So that muscle fiber is shortening again, and essentially you're getting blood supply to the area being slowly cut off to certain bits of it. So you then get ischemia. So that's death of the tissue. Okay, and you get changes to elastin and collagen. And really, and all there's a lot of enzymes that will then just sort of eat up all of these ischemic tissue. Now, the old NICE guidance used to say that you didn't really need to palpate the uterus, and certainly we don't usually palpate a cesarean section uterus going back down. I would say, certainly from a student point of view, it's useful to palpate an involuting uterus to get an idea of where you roughly expect it to be on any given postnatal day. And roughly, the uterus involutes at about 1 centimetre a day. Now, this will be, you know, different for many different women for a number of reasons. But my rationale for saying, you know, do have a feel as a student, see where that uterus is. You're expecting it to be central, so, you know, in the middle, you're expecting it to be well contracted, and you're expecting it to slowly go down. So really by day 10, day 12, if you were palpating, it should be more or less back behind the pubic bone, and so you wouldn't be able to palpate it at all. But there are various things that will influence that. You know, if she's had a very big baby, it might be slower going down. If she's had a cesarean section, it might be slower. If she's had multiples, it might be slower. So there are a number of things that will affect the rate of involution, but it is useful to roughly know where you would expect it to be. For example, if I went to visit someone on day 5 and I palpated and their uterus was still up at the umbilicus, that would ring alarm bells for me, and I would want to investigate further just to make sure there is no signs of infection. She's not constipated. She hasn't got a full bladder. There are a number of things that could cause it to be that high. But, you know, just having a feel and knowing that that's not where you would expect it to be for that number of postnatal days often does trigger you to ask more questions and just make sure that that is normal for that woman. Has she got any wounds? So has she got a cesarean section wound? Do inspect that wound. Is there any signs of, if it's a cesarean section, is the dressing off? Has she got sutures that need to be removed, or staples? Has she got any oozing from the wound? Does the wound line look clean? Is it red or inflamed? Think about your normal wound healing process, because you expect a little bit of inflammation in those very early stages of wound healing, but not sort of at day 5, 6, 7. You're not expecting it then. And similarly for a perineum. And I know over time, actually examining a perineum seems to have gone out of favour. Personally, I've never ever had anybody refuse when I've asked them if I can have a look at their stitches. It's how you put the question to them. You're asking, that you're looking to see that it is healing okay and there's no signs of infection. If I say to somebody, are you comfortable? Do you want me to look? They'll probably say no. But I have seen perineums that are very comfortable, but have been completely broken down, which means they've completely come apart. And actually that does need referring in for a doctor review. So, be very mindful about how you ask. Again, my personal practice would be to inspect the perineum when I take care over. So if in the community, that would be the first day that I visit and before I discharge her, because when I'm discharging her, I'm saying that she is fit to be discharged. So if I haven't checked that perineum has healed well or is healing well and that there are no signs of infection, in my opinion, I would be failing in my duty. And actually, to be fair, I have had an instance in the community where the documentation said there was a small tear that hadn't been sutured. And when I inspected it, it turned out to be an episiotomy that should have been sutured. So I had to refer her straight back in. So, it is important that we do consider inspecting the perineum. And indeed, the new NICE postnatal guidance does seem to favour that more. Thinking about lochia, so that is your blood loss. So it's important to discuss with women what is normal and what is not normal. So first 2 or 3 days, you're expecting it to be bright red. This is deciduous and frank blood from the sort of placental site. You're not expecting them to pass clots. And you're not, be mindful when you say to women it's a bit like a heavy period, because you need to get a baseline for what their periods are like first anyway. If you are looking after someone who has normally very light periods, then actually a normal postnatal blood loss may seem like she is pouring for her. And equally, someone who has very heavy periods, a really heavy loss may seem quite normal to them. So just be mindful. I tend to relate it more to how often are they changing their pads and how much are they soaking through those pads. So if they're changing a pad every half hour or so and soaking through it, that's a very heavy loss. But every 2 or 3 hours, that's probably a normal loss. So first 2 or 3 days, as I say, bright red. Then it will, for the next few days, sometimes few weeks, will be a serosa, what we call. So that first lochia is called rubra, and then it's serosa. And serosa is that sort of pinky brown loss. And that's because it's just got really leukocytes, mucus, epithelial cells. And that can carry on for quite some weeks, although for most women, most blood loss has pretty much stopped by 2 weeks. And then following that, you'll have alba, which is that sort of it's that sort of whitey serous fluid, which is really just leukocytes, serous fluid, sometimes a bit of cervical mucus. Talk to women about perineal hygiene, hand hygiene. Talk to them about group A streptococcus infection and the importance of hand hygiene, particularly with perineal wounds. Talk to them about the use of maternity pads, because some women will bring in the ones with the dry weave mesh on, the sort of plasticky coverings. And to be fair, they will just make, and they tend to use those more when the loss has really lightened up. But the problem with that is it can make the area quite moist and sweaty, and then that becomes quite uncomfortable for women. The perineal area becomes quite uncomfortable. So encourage them to just use ordinary maternity pads. I'm not going to talk too much about perineal care per se and the evidence that's out there in regards to perineal care, but certainly I would encourage you to research what is out there and offer women evidence-based information in relation to that. Then ask her about avoiding, how often is she going to the toilet? Remember, immediately postnatal, we've had all that 50% circulating volume, extra volume going around the body. She doesn't need all this anymore now, so she's got to get rid of it. So you're expecting an increased diuresis, so an increase in her going to the toilet for the first 2 or 3 days. Okay, so you're expecting her to pass good amounts of urine for the first 2 or 3 days. And if she's not, then you might ask yourself why. It shouldn't be painful. It shouldn't be offensive. As with the lochia shouldn't be offensive either. So when they take the pad off, they shouldn't be thinking, oh, that smells really not very nice. Has she had her bowels open yet? Most women will return to normal bowel function within 2 or 3 days of birth. But it's important that you talk to them about their diet and fiber and plenty of fluids in order that they don't become constipated, because particularly if they've got stitches, because that will be even more uncomfortable. Pregnant women and women who have just had babies are more at risk of deep vein thrombosis, because remember of all those clotting changes that happen in their blood antenatally. So they are more at risk of deep vein thrombosis. So you really need to make sure that women understand those signs and symptoms of deep vein thrombosis. So any redness, any pain, any swelling, particularly in the calves. And when I undertake a postnatal examination, I tend to run my hand along the back of the calf when I'm asking them, do they have any pain or any swelling? Because sometimes you can feel a hot spot that they haven't actually noticed yet when you're going. And then analgesia we've spoken about already. Make sure she has appropriate analgesia for her personal situation, and make sure she is aware of the dosage and not exceeding the dosage. So now let's consider the baby. So postnatally, we're looking at the baby. So look at the baby. What's this baby's general behavior? You're expecting that baby to be active. You're expecting it to have an attitude of flexion. And then look at its colour. Is it appropriate for ethnicity? Does it look well perfused? So is the blood in all the extremities? What's the baby's tone like? We're expecting some flexion there. We're not expecting a limp baby. If you've got a limp baby, something's not right. Look at its chest. Have we got both sides of the chest rising? Are its respirations within a normal rate for its age and gestation? Have a look at the cord. Is the cord drying appropriately? Talk to the mum about cord care and trying to keep it outside the nappy. We don't generally take the clamp off anymore like we used to years ago. Day 3, it used to come off. Now we just leave it until it falls off of its own accord. Ask mum about feeding. So how often is the baby feeding? How long is the baby feeding for? What about wet and dirty nappies? How many wet and dirty nappies is the baby having? What colour is the stool? And that's often a very good indication of how much food the baby is getting. You know, how if you're expecting meconium for the first sort of 24, 48 hours, but after that you should have a changing stool. So it should be that sort of browny, greeny, and then that lovely mustard yellow with little seedy bits in. And remember, breastfed babies, it's much more watery, it's much more loose. Tell parents that is normal, because very often they think their baby's got diarrhea. You know, bottle-fed babies tends to have a slightly firmer stool, but it will still be that lovely yellow colour. So, you know, plenty of wet and dirty nappies and that stool changing quite quickly is a good indication that that baby is getting plenty of food through. And safeguarding, as I said, we have already talked about. So, you know, look at how the mother is interacting with the baby. Does the baby seem well settled? This is just your daily check. I personally, if you're looking at the baby, you need to undress the baby to look at it. You know, it isn't, particularly in the community, it isn't appropriate to just sort of pop your head in the cot and say, oh yes, the baby's nicely settled. How can you check that baby's skin and whether there are any marks on that baby that you might be a little suspicious of if you don't actually undress the baby and look at the baby? It is important. You know, you have very limited opportunities now postnatally to really interact with the women and the babies. So you really need to make those count. So just thinking about key points then. So documentation, I've said, of everything that you have done, seen, advised, and make sure that your advice is evidence-based. Put a plan of care in your documentation. So when are you going to come back again? Have you given her contact numbers? Have you discussed these important symptoms that she needs to be aware of and how she can access help? And that will obviously vary from trust to trust. Some trusts, like my own, have a 24-hour helpline. Other trusts will have different pathways for women to access services. So it is important that you make sure women know all of these things. And there you have it, postnatal care. I hope you found this useful. If you haven't subscribed to the channel already, please do so, and look out for us on Facebook at The Motivational Midwife. I look forward to seeing you next time.